Why, hello everyone, and welcome to this next webinar from Let's Do Digital, Ask A Clinician. And we have got Anders Thurin from abroad for a change, from Sweden, joining us today, who's going to be talking about his medical informatics and how things are different, or maybe the same problems, same difficulties, or maybe, some of the positive stuff as well, about how things happen out there. Let me just give a quick introduction about Anders. So Anders is a consultant clinical physiologist, out in Sweden at the Sahlgrenska University Hospital in Göteborg, which in English is Gothenburg. And he has quite an extensive background history. Let me give you a quick summary. So he has a strong background in medical informatics, driven by a vision to use routinely collected data to support medical decisions and reporting. He has a particular interest in terminology standards and computer representation of medical knowledge, actively contributing to international standards development. Clinically, he focused on vascular diagnostics and ultrasonography, especially the quantification of venous disease and the use of IT for documentation and reporting. Anders, thank you so much for joining us today. I'm going to hand over to you to give us a lovely presentation about your work, and then we have a questions and answers session after that, where people in the audience can join in and ask questions, which would be lovely. But let me just share your slides like that, and the floor is yours.
Thank you. I'll do my an introduction first of all of myself. So as you mentioned, I'm a clinical physiologist at Sahlgrenska, Gothenburg, Sweden, and I'm part of the board of Swedish Association for Medical Informatics and Swedish Medical Association Committee for Digital Health, or what it's called, and standards work, as you mentioned. And also, quite recently, I'm in a committee for interoperability within the National e-Health Authority, working towards European health data space integration, where I'm not sure how that's working in the UK, because it's a EU project mostly. My history is briefly like this. I started as a programmer at Volvo in 1979 after computer courses. Then I did medical school in the 80s, and followed by internship in the north of Sweden. Then I moved to Linköping, which was a sort of the center for medical informatics, one university department for medical informatics. And I joined them in European projects from '93 in a project called Galen, and another one called Galen in Use, led from Manchester, Alan Rector's group, if you know him. And in parallel, I've been involved in standards committees, mostly in terminology, and also some report messages for diagnostic services and categorical structures for terminologies, which I'll come back to. I was also recruited for a committee in the United States called LOINC, which I'll mention later also. Then I moved to Gothenburg in '97, and I was involved in the hospital information system terminology work for a few years then. And then I have had my own project for information extraction from health records. using text processing. And also another European project led from Linköping, which was called semantic mining. In around 17 to 21, we wrote, edited and published a book in medical informatics in Swedish. And then I was involved in procurement for a health record system for our region, which resulted in Cerner Millennium, which people have worked to install that for several years now. And I had a go live event in November 24, which failed quite spectacularly. So they removed the system, and now everyone is scrambling to find what to do next, and we probably need another system. I'm also working on in a small group for defining a diploma in clinical informatics, for aiming for a future medical specialty, perhaps. We were quite inspired by things we were doing in the UK at the time, so we have similar ideas. So as you mentioned, I'm interested in systematic documentation of diagnostic exams, in particular standardized descriptions of findings and measures to support decision support, like reference values that feed into algorithms for interpretation of measurements. And then it can also be used for what's called synoptic reporting. So it's generating reports from standard representations of measurements. And if you gather data in a systematic way, you can aggregate it for research and quality assurance and statistics. So these are some of the things driving my interest. Here's a description of what's happening in a typical physiologic exam. So we have a list of observables, that's variables that we measure. And we get like a measurement, like a distance here's the diameter of the left ventricle. And we compare these to reference values, which comes from another source, and can be interpreted through an algorithm. We're here giving it's a certain distance from the expected value measured in standard deviations. And these can then be described by standard terminology, like or a reasonable language expressions that describe what we find. And then all of this is compared with the current patient problem. And we have to judge what's reasonable to find and what's relevant to mention in a report. And the point here mostly is that these things are fixed, both observables and reference values and templates are predefined and part of the method that we work with. So it's a kind of a groundwork for doing this. And here's a sort of the big picture of what I'm trying to, how I see the whole infrastructure for this informatics work. So based on medical knowledge, you train or educate people to become professional healthcare workers, and also you describe methods and guidelines for how things should be done, then, which are then described as care plans or decision support rules or guidelines, which are then sort of entered into the clinical arena and provided as care, which results in small bits of information making up the documentation, which is in part is stored in the electronic health record and reused in the care of the patients or of the patient, and some of it might be also reused in according to study protocol in research applications. So the same data might be used in several ways. But in anyway, these small items here are could be seen as observables, which are instantiated to data elements and then might be aggregated or structured to become information and new knowledge, which then is added to the base of knowledge after a proper review or analysis. And the stuff circulating here is I see as clinical concepts, which makes it important to work in the field of terminology and concept representation. And here are some of the information components that we deal with. We have problems or indications for exams, types of exams, which is a variance depending on patient category and so on. Observables is variables measured, which are listed in these things can be found in SNOMED's clinical terms. Observables are not as much, but they're probably more likely to be found in LOINC. And the CMPU, which is another terminology for observables used in Scandinavia. And then to express quantitative information, you also need to add a unit, and that can be found in a system called UCOM, the Unified Code for Units of Measure, which is basically a online database of measurement units and relative to LOINC. And also algorithms to interpret findings could be cataloged and listed in a source, which is what I mean by calling it an information component. The interpretations and diagnosis diagnoses are easy to find in ICD, or we have classifications for diagnosis. And they are also available in SNOMED. And then to report, you need to describe the structure of how you align things, and which can be described as archetypes and templates. And these are available in the open air architecture. I'll come back to that also. And it's also useful to have, in a way, it's coding systems for how you grade things. Here it's a ordinal scale for how you express a grade of something, a vascular insufficiency or something like that. Here's a way a picture that was presented to me or to the whole course of one of the first days in medical school. Sort of the point of going to medical school was to you have a physician meeting a patient, but to do a good job there, you need to know about diseases and guidelines for treatment and so on, and perhaps with clinical experience. But to be able to learn about that, you need background from here, for instance, in a specialty which is based on all kinds of medical topics, which are in turn are based on medical terminology and based on basic medical subjects. So it's a whole bag of different topics that you need as a background to work, do medical work. And it's parts I've included here something about guidelines, but in to do something about to do useful work in informatics, you also need informatics background. This is just to show an example of what observables we have in an echocardiography exam. It's sort of, that's ultrasound of the heart, where we have different dimensions of parts of the heart. So the atria and the left ventricle, nearest function, systolic function and diastolic function, and right ventricle and valves. And it's here it's how it's described on in the ultrasound machine, and it's useful to make this logical grouping to you can it makes it much easier to quickly assess whether you have done these measurements and what parts are non-normal, and so it helps interpretation. Oops. Here's just a short mention of LOINC. It's a it's an American laboratory. It started for laboratory observations, but has been extended to radiology and physiology and so on. So my observables are described by these dimensions: the system, component, property, method, scale, and time, with a sensible selection and logical ordering. And also it's a distributed as a big table with about 70,000 items, I think, with synonyms and translations, and it's used in many countries for lab reporting. Then I'm about once a month I take part in a DICOM work group. DICOM is a standard for image storage and communication, but it also has DICOM structured reporting, which makes it possible to add measurements to the images, and the measurements are identified, and what measurements are available are defined in a work group. So here, for instance, the left atrial systolic area in 4-chamber 2-dimensional view, and it's expressed in square centimeters. But here are interesting the codes for it's a DICOM identifier and a LOINC identifier, and DICOM SR identifier of the same measurement. There's also a standards project for echocardiography based on a Japanese work in standards. In ISO, I was much involved in a long time ago in what we call categorical structure, which is how you define concepts, and we call it a formal intentional definition by constrained specialization. So you have to define something, you specialize it by adding characteristics, but not just any characteristics, but they have to be sanctioned, which it means they're picked from a closed list. So in language, you do it by ventricle. No, that's a poor example. But bacterial infection of pulmonary infection is a growth of bacteria located in the lung, so it's a type of lung disease and a type of infection at the same time, and has all of these both these sets of characteristics. And this is also done in SNOMED CT in a way, and we did a very advanced set sort of intentional definitions in the Galen project. Often concepts are mapped to terminology words or phrases, or to categories in a coding scheme. And here's an example from laboratory medicine. So you make a dedicated kind of property, which is, in this case, it's a amount of substance concentration of glucose in plasma from venous blood of a fasting patient. So to get this, to describe this concept, you have the amount of substance concentration, and the glucose is taken from a blood sample. So these can be picked from different lists, and which makes the description economic in a way. Now I'm turning to my own reporting needs, sort of. Here's a system for documentation of ultrasound of the venous system, which we developed in early 2000, around 2003, based on HTML with image as scalable vector graphics and elements of JavaScript that to make these a bit interactive. The point is that you can describe the findings as a degree of insufficiency, and as soon as you enter the number here, you light up the right part of the venous system, which is, here is the anatomical parts. So each of these is a vein segment, and the finding here is represented by a colored line of a certain thickness. So this makes it illustrative, and it also makes it, we have assistants doing these exams and filling out these reports, and when you get this image at the end, you make sure that the numbers are entered in, and they are corrected to represent the correct image that you want to send out, sort of. And in the background, we can collect these numbers and use them to generate a report. So we did this about, we used it for many years, for around 15,000 patients. But then the hospital changed our image radiology information system, so we lost the contact with this system, sort of. But it's an example of usability applications. You want to make a sensible range for selection of observables. You can't, when you have a pick list, you can't have hundreds of options. You need some limits to what you select. And also you need a reasonable level of stability. For instance, if you have a data entry system, it can't change every week. At least it needs to be stable for a while. On the other hand, you probably would need to adapt it over a few months, or so you don't want it to be the same for a decade. another usability issue is that need presentation to be concise and predictable. So, for instance, a data in a table would be presented in you look at a certain part of the table for things you expect to find there. And I'm especially fond of graphics for vascular system. Here's the venous example, and here's an example from arteries in the neck, the carotid, where you can describe stenosis like this. I mean, from pulmonary medicine or spirometry, there's a company that provides reports that look like this, where you can express your measurements with the Z score to describe how far from expected it is, and here it's when it's red, it's more abnormal. I'm also involved in discussions in reducing clinician burden. It's a working group in HL7, which is the American standard, one of the American standards committees, where they have a lot of information. They have meetings every 2 weeks, so it's a lot of activity, and they're very open to interested parties to join. I can provide a link there if someone is interested. There's also something called the European Doctors Association for. I'm not sure what the abbreviation stands for right now, but they are representing the physicians' unions within Europe, and also react on EU initiatives, and it's and there was a recent document about usability and clinical burden, which is a big issue. I think maybe more in the United States that doctors are burnt out. In Sweden, we have this problem, but it's not as severe. So in my daily work, see myself as slightly anarchist, sort of, partly from necessity. But I rarely get any support from the IT department, so I do whatever I can without support, and install software in my own way as much as I can. So I think you can make small IT projects to help your daily work, and you can base them on what you know and what you expect and what you need to support your innovation and rapid development. But there is a resistance from the IT department or hospital administrators that especially the data would probably be stored in a separate way that no one understands when you leave. So you and there are some security and legal issues. So this can't be done all over the place. But the solution for these wild systems would be not to kill them, but to domesticate them. So we should aim for systems to take care of local initiatives and bring them in line with what the IT department needs by integration and interoperability, and preferably stepwise with standards and APIs, and possibly loose integration with messages between systems. And for this reason, I think, for this purpose, I think the platform of data storage and open air development is a very attractive way to include physicians with some computer interest, because they have the open air communities provide good tools for gathering physician doctors' input. But you need some informatics support and some training to do this. Open Air is a multinational project, which is, they have a lot of presence in the UK, but it originated in Australia. So the idea is that they have a reference model on which you can build archetypes describing small clinical concepts like blood pressure, and then you join many archetypes, or you make selections from many archetypes into templates, which can be presented as forms or messages or documents or APIs. And then behind these are bindings to terminology. So you represent the content of the medical data you enter is based in things like SNOMED CT or ICD or other codings, LOINC for that matter. So here's a messy picture of what it looks like, but it's a sort of the domain models and terminology are here, and the clinical users in this blue area, which are using the development is done can be done with large input from medical persons, doctors and nurses and so. And then the runtime environment is put into a platform sort of. So you separate the modeling from the software can be you don't need to have everything deeply buried in the software. You make the clinical model outside. in my daily activities, I use mostly nowadays. I use mostly AutoHotkey, which is a scripting language to make my report writing quicker and smoother. And so I have my own text template and a lot of macros to generate small pieces of text, and it's really worth looking into. It's you can make useful things with just a few lines of text. Then I'm doing some analysis of lists of reasons for encounter previously, and now it's health services for this for national project. And I do some analyzing of query forms using R, statistical language. So, for instance, we had we made a questionnaire to all the physicians in our hospital, where they reported lots of problems with the speech-to-text system. It's called Nuance Dragon 1, which people are very unhappy with. And it takes a long time, and very few that think it's worthwhile having it in its current form. It needs to be. We have to consider more to where to deploy it. And for future plans, we have some a project with a colleague in the south of Sweden for physiologic reporting, and I'm looking for some standards proposals for reference values for measurements and graphical reports to support things like this venous report that I mentioned. And here's just to mention, to document skills, there's a European project called ESCO, which is so this is ESCO's definition of clinical informatics manager. And it seems that they have a lot of interesting skills and knowledge that I thought it seems like it can be developed to something useful, even if it's not used much now. I think that was my last slide. Yeah.
Anders, thank you very much. That was amazing, and it was amazing listening to all that and seeing how many things we share in common.
Okay.
Come to the Solar Millennium in a second, actually. But first of all, I used to live in Linköping, in Helleborgsvägen, a long time ago, in '95. So that a long time ago. It's funny that we're probably there at the same time. But it's lovely to hear about how you're using the same standards as us, SNOMED, CT, LOINT, open air, and it's amazing how much open air is used around the Nordic countries, with Sweden, Finland, Denmark, and so on. We are using it quite a lot in the UK, especially around London, less further afield, but there are some hospitals using it. I wish more would use it because it's just a lovely standard to work with. And AutoHotkey, I love AutoHotkey. I use that myself quite a lot to automate. So for people that don't know what AutoHotkey is, a robotic process automation. It controls your keyboard and your mouse, and it just automates all the little things you need to do to get things done quicker. It's fantastic. I love the HL7 working group to reduce the clinician burden. I think if we had more time, I'd love to talk through that and figure out how they're reducing the clinical clinician burden, because I'm writing at the moment a clinical decision support system module, bite-sized module on that. And there's a lot of burden with alerts, fatigue, and all the things around that we get burdened with. It tires us out, it burns out clinicians and so on. And I've got loads of my own questions, but Grant's beat me to this. So Grant Valence, who's a colleague of mine, friend of mine, who works in Oxford, who has Cerner, fortunately or unfortunately, at Oxford, has asked a few questions. Just to add my own bit to that, I work in Swindon, which is another town in the UK, and we're thinking of getting Cerner, along with 2 other hospitals, including Salisbury and Bath. So we're implementing it, or we have it here. And what Grant has asked, and I will pop up his question, is, so how did the Cerner, or as now known, Oracle Millennium, fail exactly, and what were the issues?
I think the main issues were first of all, they had to translate it to Swedish, and they worked a lot on that, and they tried to anchor it in clinicians, but not many were interested, and they had too little clinical input, I think, but mainly it's cumbersome to use, and things take a lot longer time, and it wasn't quite functioning properly when they started. So they run it for 3 days, and everyone was there was chaos in Borås, a small town where they had it at this medium-sized hospital and all the surrounding GP offices. But everyone agreed that this doesn't work.
Wow.
So, but mainly it was complicated to work, and was not compared to the previous environment.
So, sorry, go ahead.
Yeah.
And so how long did you have it for before you pulled the plug and took it away?
3 days.
That was, wow. Okay, so it was that bad. And when you were implementing it, how much clinician input did you have in terms of building and implementing it, and you had the user-centered design?
I think they had they were going at it for 3 or 4 years, and they had some focus groups that did sort of to design user interfaces for particular areas and so on. But I think no one had seen it working. Even the week before they started it, they hadn't really tested thoroughly with the clinicians, because it wasn't finished. So it's
yeah. That's a shocking story, if I may say that. All that time.
I heard from, as a clinical physiologist, we weren't really expected to use it, but some of my colleagues they got some training to use small parts of it, but their training was not focused on even physician work. They got some training in how you book patients, which is someone else does. So they just shook their head. They went for a day of training, and then they didn't really learn much.
Okay. And other, so I'm also very interested in standards and terminologies, which I think terminology is something they're very much into as well. And open air, I haven't really seen how extensive across the Nordic countries it's being utilized. I'm just wondering, across Sweden, for example, how is it across all the hospitals it's used? And no, okay,
There's a lot of interest in Linköping and in Stockholm, and I think they're trying to implement it but mostly it's still sort of experimental. It's not in regular clinical use any, as far as I know. It's
okay. And going on from that, also FHIR, FHIR, the sort of messaging standards. I wonder if that's used, and this is a question that Grant's asked as well, is that something that you use for the interoperability between services and healthcare providers, or do you have some other standard you use, or like most places, is it a mixture?
I think FHIR is the big candidate for interoperability, which is it's mentioned in many of the publications from the government, the plans for future interoperability. So that will likely be a major part of messaging and so on.
Okay. And what fills the void when you take away an EPR like Cerner? What systems do you have or don't have? Is it all paper based again, or?
No, we have a previous Cerner system, which is also a bit odd. Cerner, it's called Melior. Melior. So it's strange that the same company couldn't use what they had in that system. But they're probably so different with this new one. So.
Okay. So changing tact a bit, I was wondering, I've heard a lot of similarities with what we've got here in the UK, but I was wondering, what do you think you've learned from the UK that might help you in Sweden with your digital health, your clinical informatics? And actually, what do you think we can learn from you? Because I've learned a lot now, but I'd be curious to hear your opinions on that side of things.
There used to be a lot of British people in the standards community, and I really enjoyed meeting them there. And also we had there was very nice collaboration in this Galen projects and so on. But I think now I'm thinking mostly of standards committees where we could really have make a lot of collaboration projects in open air, which is as far as I know, there's a serious development going on in the UK in that area. And we need for our region, we need a new strategy for if it's, I don't think it's likely that Millennium will ever be. We don't trust it, so they'll have a really steep way back if it's ever coming back. We've spent billions of crowns buying it, so it's sort of tough, but
okay. And terminologies and standards, it is something that I can see you're quite passionate about. I think it can be quite a difficult subject to teach other people, especially if they don't have the sort of digital health sort of mindset. But I'm curious, how did you get into it, and how would you convince others that actually these are really important things? We need to standardize what we're doing. We need to have interoperability. We need to have terminologies that help computers understand things. You might argue that AI might be able to just do natural language processing and just read things out, in white boxes. But I'm curious, what got you into it, and how can we all be as passionate?
I think I was looking for, after medical school, I was looking for how I could combine this medical knowledge with computer, and the at that time I think I considered the issues around medical terminology was where I could make most difference in comparison with computer people, sort of. And then there was the Galen, which was very inspiring sort of project but they did this thoroughly and made a good arguments for working in this area.
Okay, fantastic. Now, the AutoHotkey, the R scripts, so R scripts for other people listening in is a programming language, but used for data analysis more than anything. It sounds like you're very much a clinician who codes, which I love. I would love to see your code actually, if it's on GitHub or wherever else you might be storing it. But that's a conversation for another day. I do think we're running out of time though, so I'm going to slightly wrap things up. Anders, thank you so much for coming along, so much for sharing how things are going well, or with CERN Millennium badly, and it's worried me a bit how I might get involved with things here in the UK.
But can I?
Yeah.
So you're introducing Millennium at your
3 hospitals, yeah.
How do you feel about that? Does it seem like it's going to be working, or?
I probably shouldn't say out loud what I think, but I'm worried is probably the nicest way to put it. And I want to be involved as much as possible to make sure it works as well as it can. That's probably the nicest way to describe how I feel about it all.
At least they didn't have to translate it to use in the UK.
Yeah, no, but some Americanisms may come across. Who knows?
Yeah,
who knows?
Yeah.
But no, Anders, thank you so much for coming along. It's been a pleasure talking to you. For everyone else listening in, we have now the Let's Talk Digital conference tickets available for the 23rd and 24th of October. You can join remotely or in person, so please do register on the letsdodigital.org website. Anders, many thanks once again for coming along, and I think maybe it would be great to have another show with yourselves and other colleagues in the near future to talk about how things are going in Sweden or other Nordic or even European countries. So thank you very much, everyone. Bye for now.